Hello everyone, welcome back to the Orthopedic Tutor channel. Last week we have discussed extensively regarding the brachial plexus anatomy, all the basic anatomy and also those that are relevant to discussing and to understand the brachial plexus injury. So today we are going to switch our focus to the brachial plexus injury itself. Now the brachial plexus injury is actually a very big topic. You need to know a lot of things so that you are able to manage a case of brachial plexus injury well in the best manner possible. So I'm going to break down this video regarding the brachial plexus injury into two parts. The first part will talk about the causes, the signs, the types, the physical examination, and also the additional examination, while the second part of this video will talk about the non-operative and also the operative techniques that are available. Now, let's move on with the first part of this video. Now, for the brachial plexus injury itself, before you try to understand the injury to the brachial plexus, first, you need to know about the basic anatomy of brachial plexus. So be sure to log in and watch my previous video regarding the brachial plexus anatomy before you move on to today's discussion. Now, after you have known the anatomy, the brachial plexus injury itself, it could be caused by many causes, but I basically would like to remember it as these basic three types, which comes from the obstetric brachial plexopathy, which occurs in the pediatric population, or those brachial plexus injury that can be traumatic or are traumatic in its nature. Now, for the traumatic itself, it could be caused by a high energy or a low energy type of incident. Now, the signs of patients who comes with a suspected brachial plexus injury is variable because it has different manifestations according to the types of the plexus injury itself. Now, basically, there are various signs that can lead you to a diagnosis of brachial plexus injury. There could be a pre-existing preganglionic signs, there could be a postganglionic sign, or they could present with a signs of severe injury. Now, for patients who have these signs, they are considered as patients with a suspected preganglionic signs. If the patient have winging signs, Horner syndrome, sensory or motoric loss, tenderness to percussion, normal histamine test, and also elevated hemidiaphragm. We'll discuss more about this later on in the part of physical examination. Now, for the postganglionic sign, generally the patient will present with motoric or sensoric loss and abnormal histamine test. Now, for the severe injury type, generally the patient will present with complete loss of the sensory function, global motor dysfunction, neuropathic pain, or even Horner syndrome. Now, basically, you do not need to memorize all of these because it should come naturally to you after you have watched the next part of this video, which is about the physical examination. So if you know how to do a good physical examination, then you could mention all these signs without even having to take a look at these signs again. Now, moving on, the types of brachial plexus injury is very variable, but most of them is a panplexus injury or the injury towards all the nerve roots, which is starting from the C5 down to the T1. Other types also exist, such as the ones that involve the C5-C6, also known as the Erb or Erb-Duchenne palsy, or the ones that involve the C7, which is also known as the Erb plus pattern. These patients generally also has symptoms of reduced wrist and finger extension motion. Now, other types would include the C8 or T1 injury, which is known as the Klumpke or Dejerine-Klumpke palsy. Now moving on, you need to know how to do a good physical examination, because this is frequently a very challenging task for any doctors or any residents that are still studying about the brachial plexus. You know the plexus is a very complex structure, but you also need to do a physical exam that is well organized to help you localize the localization of the lesion itself. So the must know is the goals and the general rules of physical exam. For the goals, you need to do a good physical exam because you would like to pinpoint the location of the lesion. You want to determine your treatment plan based on your findings, but on the same time, you also would like to determine the prognosis of your patient's condition. Now, generally, there are rules that you need to follow so that you could do a good physical examination. I tried to put together, and I find that these 4 points are very good thing that helps me along my practice and along my study while I'm still a resident. So the first thing that I need to do when I find a patient with a brachial plexus injury is to determine what type of palsy does he has, whether it is a whole or panplexal type of injury, or whether it is an injury that involves only the upper or the lower type or part of the plexus. So what I do is I have my patient stand in front of me and I ask them to generally move their upper limb, and I try to do a motion and I ask them to mirror the motion that I do. So generally what I do is I try to abduct my upper limb, I try to flex my elbow, and I try to move my fingers. So when I absolutely find no movement while I ask the patient to mirror my motion, then generally this is called a panplexal injury or injury towards the whole brachial plexus. And while some patients generally have some residual movement, if the patient has an upper plexus injury, then usually the hand function is well. So the patient cannot move their shoulder, but the patient can still flex and extend their fingers. While the reverse is true, in the patient that presents with a lower plexus injury, then the patient generally has loss of their hand function. Now, by doing this simple task of mirroring, then I have already figured out whether this patient has a full plexus, upper plexus, or lower plexus type of injury. The next, what I would like to determine is whether this injury is a pre-ganglionic or post-ganglionic injury. Now, as you might recall this picture here from my previous anatomy video, these are the ganglions and these provides the sensory innervation. So injuries that occur before this structure or occur around here, they are known as the preganglionic injury, while the injury that occurs after this root ganglion, that would be known as the postganglionic injury. Some of you might notice that all the nerve root branches, they all come after the posterior root ganglion or over here. But we use some of those nerves to help us identify preganglionic injury because of its proximity. If these roots, the branches that comes off from these roots here are injured, then we generally could conclude that the injury is located around here or around the preganglionic area. So once again, when I show you this anatomy picture here, okay, so these branches here of the phrenic, dorsal scapula, long thoracic, they all come from the root, and the ganglion is actually situated here or proximal to the C5. But because of its proximity of these nerve branches and the ganglion itself, so injury towards this nerve generally means there is injury towards the preganglionic area, and that's why we call them a preganglionic injury. Okay, so now moving on. Now that you have known about the relevant anatomy, you should be able to guess what the upper plexus injury would present with. If the injury involves the upper plexus, then generally the preganglionic sign would be winging, because during the injury of the upper plexus, there could be injury to the dorsal scapular nerve, long thoracic nerve, which in total will cause a medial winging. But you need to be aware of the other types of winging, which are the lateral winging, are also caused by, which is caused by the trapezius or the 11th cranial nerve. Now, to differentiate these two types of winging, you need to notice where the lower angle of the scapula moves to. When it goes towards the medial, then it is a medial winging, and when it goes to the lateral area, it would be a lateral winging. Now, the winging that we are talking about in a brachial plexus upper type preganglionic injury would be a medial winging. Now, the next thing we need to do to find is the preganglionic signs for a lower plexus injury. Now, whenever we talk about preganglionic over at the lower plexus injury, we always talk about Horner syndrome. Now, the reason behind this is that the Horner syndrome, I'll show you this picture first. Okay, and also this picture here. Now, when you talk about the Horner syndrome, it is actually a collection of symptoms that occur in a patient, and it includes these four types of manifestations, which are ptosis or droopy eyelid. There will also be miosis or constriction of the pupil. There will also be anhidrosis or inability to sweat, which shows that the skin is dry, and also sometimes there could be hyperemia or flushed skin. Now, moving on, this Horner syndrome can actually be caused by any types of lesion around the central area or around the hypothalamus. It could also be caused by a preganglionic or a postganglionic injury. Now, the ones that we are talking about today is the ones that have a connection to the preganglionic type of tract. We could see here the black colored one arrow here is the descending tract coming down from the hypothalamus, and this red here, pink arrow here would be the preganglionic tract, and the dotted line here would be the postganglionic tract. As you can see here in this other picture, that the branches coming off from the T1, they innervate or they become part of the nerves that innervates the eyes and also the structures around it and also the skin. So T1, as we all know, is also part of the brachial plexus, and that is why in an upper plexus injury, you cannot find a Horner syndrome. It is only present in a lower type of plexus injury. So after you have known the location of the plexus, you could correlate it with the Horner syndrome finding. As you could see here, the parts of this T1 nerve will give branches off to our sweat glands. Now, these sweat glands, when disrupted, will cause anhidrosis, which is the inability to sweat around the face, the skin around the face of the affected site. Now, other branches that goes off to the eye is shown here as parts of the superior tarsal plate coming off from the short ciliary nerves. These are the short and long ciliary nerves are also nerves that comes from the autonomic nervous system, which comes also from the T1. So these nerves innervate the levator palpebrae superioris muscle and also the superior tarsal muscle or the mular muscles. So any disruption to these muscles innervation will cause us the inability to properly raise our eyebrow, and therefore the patient will present with a droopy eyelid. We ask the patient to open up their eyes, but one part of their eyes which are affected could not open up maximally. Now, the next finding would be miosis. The reason behind this miosis is this is depicted clearly in this picture here. We could see here that the pupillary dilator muscles, or the muscles that dilate our pupil. It comes from this plexus of nerve here that branches off from the T1 via the muscle via the long ciliary nerves here. We could see here that these ciliary nerves, they go to these pupillary muscles, and therefore any disruption to the pupillary dilator muscles will cause our eye the inability to properly dilate, and therefore the patient shall present with miosis. So the method to detect the miosis is not by giving the eye a direct source of light as you would when you usually check for the pupil diameter. So the way for you to do a good physical exam to detect this miosis is actually to reduce the amount of lighting around the room where the patient is placed, because as we know, in the darkened area, generally our pupil will dilate, and this eye, which is affected in this Horner syndrome, will remain constricted because it is unable to dilate. Now, after you have known what causes the Horner syndrome, the next thing I would like to talk about is how do you objectively measure those things. Now, one of the part of the Horner syndrome that you might have noticed is the sweat test. So the method to do the sweat test, there's actually several types of materials that you could use, which are a mixture of alizarin red powder, cornstarch, and also sodium carbonate, also a mixture of iodine or cornstarch. Now the color would be different. If you use this mixture, then after around 30 to 60 minutes waiting for the patient to sweat, generally you put the patient in an area with an increased temperature so that the patient would be forcibly sweating. So the color of the powder that you place on the skin would turn from yellow to red, while for this mixture the powder would turn from brown to iodine if the patient sweat. So you can see here the sweat test is also known as the thermoregulatory sweat test, where the patient is coated with a powder which could change color when and where you sweat. So the patient is then placed in a chamber that causes the body temperature to rise, and then digital photos will document the results. So after you have done this sweat test, you could determine whether or not this patient has Horner syndrome. Now the last part of this examination, when you have determined that it is a postganglionic injury, is to determine the location of the injury, whether it is around the trunk or the cord. So I'm going to give you this information here, which is the flow. This flow is developed by my teachers back during at the residency, and it is being taught to us, and today I'd like to teach it to all of you. So this flow here lets us evaluate the brachial plexus injury systematically, so you do not miss anything while doing a good physical examination. So the first thing you do is to stand in front of the patient and then do a mirror test. After you have done so, you have already get a good grip of diagnosis, which is an upper injury, lower injury, or panplexal injury. Now, if the patient apparently has signs of upper injury, as I've described before, then you move on to the back of the patient. You stand behind the patient. Now, what you do here is you try to identify whether this upper plexus injury is a preganglionic or postganglionic type of lesion. Now, if the lesion is preganglionic in nature, then you need to look at the function of these two nerves. You need to check the rhomboid muscle and evaluate the dorsal scapular nerve. You remember that when checking the rhomboid muscle, you need to place your hand right on the belly of the rhomboids to detect any palpable muscle contraction. Now, for the long thoracic nerve, you need to check for the serratus anterior and to notice any medial winging. Now, if the patient does not have these signs, or the patient has no winging and good rhomboid function, then generally the patient has an upper post-ganglionic injury. Now, once you get a good grip that this patient has a upper post-ganglionic injury, you need to determine whether the lesion is over at the trunk or at the cord. So once again, I'm going to show you this anatomy picture here. So once you know that the patient has an upper lesion, and you know that it is not a pre-ganglionic injury, it's a post-ganglionic injury, you need to determine whether the lesion is over here at the superior trunk or at way down at the cord or even the branch region. So what we do is we do a certain physical examination to differentiate these two parts. So let's go back to this area here. Okay, yeah. So if the patient is having if the involved area is the upper postganglionic region, then generally you need to check the function of this nerve, which is the suprascapular nerve. By doing so, you need to check the supraspinatus function and also the infraspinatus function. If both of those muscles function is lost, then we say that the patient has an upper post-ganglionic injury over at the trunk region. Now, if the patient still has a good supraspinatus and infraspinatus function, then this area here is good. So the next thing you do is to look further into the cord. Now, the cord that you can check here is the functions of the pectoralis major, musculocutaneous nerve, or median nerve. Generally, if all of these above things are normal, then the patient has a lesion over at the cord region. Now, the same thing also goes for the lower plexus, but the different thing is because what you are going to inspect mostly are the functions of the hand, and also you will be looking at the Horner syndrome. So for the lower plexus type, it's best if you stay at front of the patient. So to determine whether it is a pre-ganglionic or post-ganglionic injury, for the pre-ganglionic, you need to check for the Horner syndrome. Once again, Horner syndrome is positive in a pre-ganglionic injury because of its T1 nerve contribution. You cannot find Horner syndrome in an upper plexus type of injury because there are no contributions coming from the level above the T1. Now, for the post-ganglionic signs, you cannot check the trunk injury to the trunk region because there is no branch coming out of it, and so is the division. There is also no branch coming out of it. So the only thing you could check for post-ganglionic is to find out which cord is affected. Is it the posterior cord, medial cord, or even both? So for the posterior cord, the nerves that you could check are the upper subscapularis nerve, the thoracodorsal nerve, and also the lower subscapular nerve. So you do the examination of this nerve by checking the function of the latissimus dorsi muscle or the subscapular or even the teres major muscle. Now, the thing about medial cord is that you could also check for the medial pectoral nerve function, which is detectable while evaluating for the function of the pectoralis muscles. Now, moving on, after you have a good grip of where the lesion is located, is it the upper type, lower type, preganglionic, postganglionic, and you could even localize it whether it is at the trunk or the cord, the next thing you do is to confirm your diagnosis. Although you know that this physical examination gives you a good description of what type of where the injury is located at, you still need to do some additional examination to help you be sure of your own diagnosis. I'm going to go first to this test here. Now, histamine test is very much discussed in a lot of textbooks, so you need to get a good grip of what histamine test really is. So what you do on histamine test is you do examination on each of the dermatomes that is involved in the brachial plexus, starting from the C5 down to the T1. So for each of these dermatomes, there are specific area where this test is being done. Now the next thing to do after you have known the area to do this test is how to do it. So what you do is you need to scar the skin using a needle or maybe the back edge of the knife. The thing is you just need to scar the skin but do not make a wound towards the skin. So after you have scarred the skin, the next thing you do is you need to apply a histamine solution of 1% concentration. And then what to expect would be a positive or negative finding, because a positive finding would mean that the lesion is a preganglionic lesion. Remember that histamine test actually tests the integrity of the nerve way down from the branches up to the ganglion. Okay, so I'm going to show you the picture one more time. Okay, this picture here. So what histamine test is trying to do is to detect whether the integrity starting from this posterior root ganglion down all the way to the branch, whether it is still intact or not. If it is still intact, then generally the patient has positive histamine test, and that would mean that the injury occur above this root ganglion, or also known as a preganglionic injury. Now if the test result came out negative, it means that the continuity of this area starting from the posterior root down to the branch is already disrupted, and that would mean that it is a postganglionic type of injury. Now moving on, after you have scraped the skin and applied the solution, what you need to observe in a positive finding is the Lewis triple response. The first response would be what we call as a redness, or the initial small erythema, also known as the primary hyperemia. Now the next thing would happen would be the edema, and the third response that would occur would be the large halo hyperemia. Now this is also known as a secondary erythema, or also known as the neurogenic inflammation. Now this third finding here is what differentiates a positive and a negative histamine test. If the test is negative, then only the first and second reaction would occur. So only the primary erythema and also the edema will occur, but there is no neurogenic inflammation, and therefore the patient would be considered to have a postganglionic lesion. Now, the other examination that you could do would be the EMG and nerve conduction study. Now, for the proximal nerve, you could evaluate it using various studies such as the H reflex, F wave, and you could do the somatosensory evoked potential test over at the ear point. While for the peripheral nerve, what you could check is the sensoric function and also the motoric function. If the sensoric function are also checked with the sensory nerve action potential, if it is preserved, you could say, in a preganglionic lesion, then generally this SNAP will remain normal, because once again the nerve all the way from ganglion to its branches are still preserved. Therefore the SNAP is also normal. So normal SNAP with an insensate median nerve distribution would mean that the patient has a preganglionic injury towards the C5-C6 root. And if the SNAP remains normal with insensate ulnar nerve distribution, then the patient has a preganglionic injury towards the C8 all the way to the T1 level. Now there are various things that you could check for the SNAP. which includes the conduction velocity, the latency, and also the amplitude. Now for the motoric function, the test that you do is known as the compound nerve action potential, and also in this test you evaluate for the amplitude, latency, and conduction velocity. Now the next test that you could do is the plane radiograph. Now some of you might think that this might not be relevant for a patient with brachial plexus injury, because in plain radiograph, you cannot visualize the nerve. But generally what we would like to see here in the plane radiograph are indirect signs of the brachial plexus injury. For the cervical radiograph, because most or some of the brachial plexus injury occur because of traction injury, you could find an avulsion fracture of the transverse process of the spine. While for the chest radiograph, we do this to evaluate for any evidence of high energy injury, such as those seen in the scapulothoracic dissociation. You could see that the distance between the medial border and the scapula towards the spinous process is different when compared right to the left. Now, other signs that you could find in a chest radiograph is the diaphragmatic height. You ask the radiographer to take this picture in two positions, which is the inspiratory position and expiratory position. So during maximum inspiration and maximum expiration, you need to evaluate the height of the diaphragm, because you know that part of the phrenic nerves come from the C5. So if the phrenic nerve is involved, there will be hemiparalysis of the diaphragm and therefore inequality in the diaphragm height. Now the next thing you could do are the MRI and also the CT myelography. Now the MRI is very good because you need to do it you could do it to visualize evidence of any brachial plexus injury. So you do it when you suspect an injury that occurred distal to the nerve root, and what you would like to see is the traumatic neuromas or edema that occur around the area of the injury, or you could also reveal some mass lesion in the cases of a traumatic brachial plexus injury. Other things would be any signs of injury towards nerve root, because it would usually heal with a pseudo meningocele. There could also be a empty nerve root sleeves, and also some of it may show you a cord shift away from the midline. Now, generally the gold standard that you could use to detect a brachial plexus injury is the CT myelography, because it allows you to visualize injury at the level of nerve root, because generally avulsion of roots may cause the dural sheath to heal with the formation of this meningocele. So I think that would be all for the coverage of this additional examination for brachial plexus injury. So last I would like to show you is this table here that helps us differentiate whether the lesion is a neuropraxia, axonomasis, or neuromasis, because in the neuromasis type of examination, in the neuromasis case, you generally find absent of all these functions and only positive abnormal spontaneous potentials in the electromyography. While on the neuropraxia, generally all of these are still normal, while there is no findings of abnormal spontaneous potentials in the electromyography. I think that would be all for today's discussion regarding the first part of the brachial plexus injury, which is the basics on how to diagnose, how to do a good physical exam. Next video we'll discuss about these non-operative and also operative methods of brachial plexus injury. If you like to watch more videos, please like and subscribe my channel, which is the Orthopedic Tutor channel. Thank you for watching and see you next time.